delighted that Liz has agreed to join us. So this is Professor Liz Orton, who's a Professor of Public Health at University of Nottingham and a public health consultant from Leicestershire County Council. But today, here to talk to us about implementation and spread and scale of interventions, and based on her experience of what she's done recently, because it's pretty amazing. So no pressure, Liz, absolutely. We will, of course, take questions, comments, points for discussion at the end. So yeah, please, Liz, over to you.
Thanks, Emma. So what I did isn't amazing. The amazing bit was developing the intervention that we've been studying. So today I'm going to talk to you about how we can use the research theory around implementation science to help influence the spread and adoption of interventions. And I'm going to focus in particular on a case study of a program and intervention that I didn't develop. I didn't do the original testing, but I am really interested in it as a public health intervention, and it's called the Falls Management Exercise Program, or FAME. So that's the plan. So the session, I'm going to introduce the case study. I'm going to introduce FAME as to tell you a little bit about it, because I'm sure not many people will have heard of it. And then I'm just going to summarise the research that we've done as part of the ARC-funded or previously Clark-funded projects called Physical, and a more recent one called Flexi. And then what I'd like to do is then apply that learning of theory into what can we do to influence spread and adoption of interventions. Because it's great doing the implementation science, but then what we want to actually do is effect change at the end of the day. So the FAME programme aimed at older adults, a falls prevention intervention, but it also has some other benefits as well. It's shown to increase people's physical activity generally, and also, as you'll have heard there, it has social benefits, well-being, mental health, though those aspects haven't been studied in clinical trials, but they are commonly reported by people who take part in the programme. So this intervention was developed in the late 90s by Professor Dawn Skelton, who's now at Glasgow Caledonian University. And she was an exercise physiologist, really keen on trying to prevent falls from happening in patients who had Parkinson's disease, and also women who were frequent fallers, and because of the risk there of osteoporosis and bone fracture. And so she developed the intervention from her exercise physiology background and then tested it in these frequent fallers, but it was a longer program then. It was a 9-month program, and she showed that FAME was effective, or this intervention that she developed was effective at reducing falls and falls injury. And then it wasn't until sometime later in the around 2014 that the first big clinical trials, big randomised controlled trials were undertaken. So the PROACT 65 trial compared FAME with another strength and balance exercise program called Otago with usual care. And that was the big kind of HTA landmark study that showed that FAME was effective at reducing falls and was better, more superior at reducing falls than Otago. And then, so that's the clinical trial showing that the intervention works in a very controlled, kind of researcher supervised environment. And at that time, I just started working at Leicestershire County Council as a consultant in public health, commissioning programmes to increase physical activity in the population. And we didn't really have anything that was suitable for older adults. And so because I was at Nottingham, the HTA study had just been published. We thought, well, actually, should we implement FAME as part of our suite of interventions in Leicestershire? And that led us to then apply for funding to study the implementation in the real world. And so we were successful in receiving Clark funding to look at FAME implementation without researchers kind of, intervening and kind of being, scrutinising the fidelity in Leicestershire, Rutland, and also Derby City. Derby City is quite a different demographic to Leicestershire and Rutland, and so it was quite interesting to see how the programme would work in different areas. And that was called the physical study. So we were looking at the real world implementation to see if the clinical effectiveness that we'd seen, or clinical efficacy that we'd seen in the studies, was translated into real world effectiveness, but also to look at, well, what changes when you haven't got the researchers kind of peering in and monitoring every nth degree of detail. what changes with a programme? How is the fidelity altered? And then that led to us at that time developing something that we called the implementation toolkit, because I was a commissioner of programmes and we often have to start from scratch in terms of thinking about the logistics of implementing interventions. I thought actually it'd be really good if we put everything we've learned into one place, into a toolkit, so that we can go from, well, here's how you write the business case. In fact, here's a sample business case to make the case for funding. Here's a specification that sets out exactly what you want to commission. Here are videos, you've just seen one, which can be used in your promotion of the programme. We had clinical letters, we had Gantt charts, we had training plans, a minimum data set, all sorts of kind of guidance that you would need to implement the programme. So that was the first iteration of the implementation toolkit, and you can download it if you scan the QR code. And then that was fine. It's kind of interesting. We learned quite a lot about what it takes to implement the programme. But then there was another call for funding from, again, from the next version of Clark, from the ARC, but down in Wessex, who were interested specifically in interventions that had been tested in clinical trials, tried in small areas, locations, but then looking at larger scale up questions. And so we were successful in achieving funding to undertake a study that we call Flexi, which is still in progress, where we looked at the spread, adoption and implementation of FAME in Devon, which is a large rural locality where it's the integrated care board, the footprint of the board, the integrated care system is the same as it's just one integrated care board in the whole of Devon. And then we looked at Greater Manchester, where it's a combined authority, so it's a different kind of political and commissioning landscape, where there are 10 boroughs of Greater Manchester have all come together as one combined authority. So we looked at how FAME could be implemented in Greater Manchester. And then we also looked back at those sites that we had studied during the physical programme, nearly sort of 10 years on, to see what had changed. So were the programmes still running? Was the fidelity maintained? Had anything adapted or changed so it was still to make it not recognisable as the FAME intervention? And the idea is that we'll use the learning from Flexi to update the toolkit. And we're just moving into a new phase at the moment where we're looking specifically at sites that have done reach well. So if they've reached more men than is usual, you'll have seen on the video there was only 2 men in that class, and that's quite normal. So have any programs successfully recruited more men into them? Have they been delivered in very deprived, disadvantaged areas, rural coastal areas, areas where you might need to consider things like transport or cost of the programme more? And also, are there any programmes that have considered how to engage minority or underserved communities? So we're looking for those case studies now to study them over the next 12 months. And all of that, again, will be used to update the toolkit. So these are the research questions that we asked for the 2 studies. For physical, it was about the clinical efficacy being translated into real-world effectiveness. So we looked at routine data to see if outcomes improve, the functional outcomes in the participants. We looked at the fidelity in the real world. So what things, do the instructors stop doing because they're a bit difficult or complicated, or they don't think people like them? And then also what makes real world implementation successful? So what are the factors that helped those areas adopt the programme? What were the facilitation and the barriers, facilitation factors and barriers? For the Flexi study, we've expanded the questions slightly. So we're interested in kind of, whilst the implementation question in physical was very much about the delivery of the programme, in Flexi, we're interested in looking at what works to foster the initial adoption of the programme by commissioners. So now we're not providing any funding for FAME. We're just saying, hey, Devon, here you go. Here's an evidence-based intervention. You've got it in one area. What does it take for Devon to take it on as a system and increase availability? And similarly with Manchester, they had lots of programmes that looked a little bit like FAME, but weren't actually FAME, being delivered for a long time. What does it take for them to sort of take a systems view of, well, actually, should we be doing something that looks more like the evidence? And then we looked at delivery in the real world. So we're looking again at what does it cost in these different settings, these different types of authorities and commissioning systems. And then we've had a specific focus on what it takes to maintain the quality of and fidelity of a programme over time. So we worked with Later Life Training, who are the national providers of the training programme for FAME, so they train the instructors, and they set up a community of practice where instructors or commissioners or managers could join in and ask questions about delivery problems and problem solve with each other and talk about quality assurance and quality improvement. Our research methods were probably, fairly standard, really. We interviewed a range of, for both studies, we were interviewing commissioners, providers, and participants of the programmes. We observed classes. We had external quality assurance visits. Again, it was Later Life Training who came in, observed classes, and gave us data on the quality and fidelity of programmes. We looked at things like register data to see what the attendance was like. We looked at functional outcome data because as part of this programme, they do collect outcome data at the beginning and end so that they can see how well participants have improved or how much they've improved. And then we also undertook some document analysis, so looking at meeting minutes, looking at anything that was kind of anything written down really that would show us or give us information about implementation, adoption and spread. When we were looking at the fidelity of the delivery of the programmes, we used, in our analysis, we used this implementation framework by Carroll et al. And we use this to kind of look at, to just basically break up the components of the programme to say, well, what does the content look like over time? What does the reach look like over time? Are the classes being delivered as you'd expect? That was the kind of adherence questions. And then we also looked at the moderator questions. So what are the things that they're doing locally to help the programme both be adopted and then implemented? So, for example, in some classes, they would have an additional instructor in there so that they could get more people into the class and feel confident that they'd be able to support everybody's needs. So that would be an example of a facilitating factor. Another one might be to have tea and coffee after the classes to encourage people to stay, make friends, and then want to come back the week after. So we captured those as well. And then for the questions around initial adoption and implementation of the programme, we use the CIFA framework to code our data to see which elements were important or seem to be important in these different settings. So I won't do a kind of 101 on CIFA, but it's basically looking at the different, from many studies of implementation. This framework has been developed, compiled together to identify the most common or most important factors that seem to be needed as part of spread and implementation. So we looked at our data to see which of those constructs were most common. And in particular, this is now kind of moving on to what we found, but we found that particularly for the Flexi study, where we were looking at the initial adoption of the programme, that some of these themes were much more important than others. So those in yellow were the themes that really came out as being important, and I'll go through those in a little bit more detail. So for the physical study then, and again, this is just a whistle-stop tour of the studies because I want to get on to the kind of how we apply in this learning bit. But the question, is the clinical efficacy translated into the real world? Well, as far as we could tell, the answer is yes. Now, I say as far as we can tell because we didn't have a control group, but we did look at the data before and after the programme, and for physical, we had a 6-month follow-up time point as well. And so we were able to see similar effect sizes in these real world classes as we did in the PROACT 65 trial. For the question about fidelity of the programmes being maintained, well, I've put there largely speaking. So there were elements of the FAME intervention that were delivered with high fidelity, and then there were elements that tended to get kind of missed off. So as part of the programme, because it's not just about preventing falls happening, FAME is also about, if you do have a fall, how do you recover from that quickly? How do you get up off the ground to stop, so you don't have a long lie? And so what we found was that elements like Tai Chi, which is an important cool down element of the programme, was sometimes missed off because the instructors didn't feel very confident to deliver that. Elements of getting people down onto the floor and then back up again were often missed off because, again, instructors didn't feel confident to do that. As you age, it does become more challenging then to get down onto the floor and back up again if you've not got very strong legs and you're kind of creaking at the joints, and people get worried about it. And so the instructors didn't want to get people onto the floor because they were worried about getting them back up again, and they were worried too about participants kind of not coming back the week after because they'd been put off. So these kinds of this insight, listening to instructors, listening to the participants, triangulating that together and putting a kind of myth busting kind of sheet together was an important output from that part of the study. And also that feeds into both the training that later life provide, so that we could say to them, look, it's really important that you stress the importance of Tai Chi and you stress the importance of getting people down onto the floor as part of the instructor training. But then also we could implement, we recommended a kind of quality assurance program, and we made sure that all of these elements were included in that program. And then what makes real world implementation successful? So this is kind of getting the programs up and running in a local area. What was really important was having a community of practice for the instructors. So instructors in the leisure sector are often freelance. They kind of come in, they're commissioned, or they're employed to, well, not employed, they're self-employed, but they'll be asked to deliver certain programs. They'll come in, they'll have an hourly rate. They might recover their costs by charging the participants, and off they go again. And they're not really supported in between delivery of classes. And so getting those instructors into a forum where they can talk to each other about challenges of implementation was really important. And also in the early days of that community of practice, they had the service managers come along and they could talk about the kind of nuts and bolts of the management of the programme and data collection and things like that. So, and that was really important. So in the early stages of the community of practice, it was very operational, kind of from a, management point of view, but then over time it became more important for the instructors where they could talk to each other about delivery. The policy context was really important. So trying to implement a new programme in a local area where there isn't a political or a kind of local health need and will to implement that programme was pretty much a non-starter. So having the right policy context locally and nationally, so having the NICE guidelines supporting intervention and the World Falls guidelines, that was all helpful in making the case for FAME. But really the relationships between the participants and the instructors and the managers and the commissioning leads were all really, really important. And everybody, all of those tiers need to be an advocate of the intervention. And of course, funding, you can't run these programs without funding unless you're going to completely recover your costs through charging people. But then that means some people won't be able to afford to come to your classes. So if you want free classes, they have to be paid for through some mechanism. And that obviously was a real sticking point for many programs. So moving on to the Flexi study, where we're particularly interested in spread and fidelity. So what works to foster the initial adoption of FAME by the commissioners? So going back to that CIFA framework, so those the kind of factors that, having credibility of evidence of the intervention, so having that clinical trial data and that it was cited in NICE and that it was a WHO report, all those things were really important. Well, they were important. They probably weren't as important as you might think. So just getting your intervention in NICE guidelines isn't going to get it implemented. The next sort of layers of importance were things like relative advantage. So your intervention needs to be better than what's available locally or already. There needs to be some credibility of the people who developed it. So the fact that FAME was developed and tested by academics, and Dawn Skelton is an academic, as well as she set up the later life training programme, but has real credibility. She's part of that, the National Falls Guidelines group and the International World Falls Guideline group. So that credibility was super important. there has to be a local need. So there has to be, whatever the problem of your intervention, whatever the problem your intervention solves needs to be a local priority. So it needs to be up there on the things that they want to address. You need to affect people's opinions at all levels. So right from the sort of, the medical director, the chief operating officer of the ICB, right at the very senior levels through to the people delivering the intervention on the ground, all need to be advocates of your intervention. And then having some mechanism where locally they can just pick up the phone or drop an email and say, we're really struggling with this, can you help us? That was really important, and that was provided through that community of practice national platform. What does so the next question was, what does delivery look like? How much does it cost in the real world? Well, some of that is very similar to the physical results. So yes, looks like improvement in the outcomes for participants is looking the same as the clinical trials. We're now updating some of the cost data so that there isn't the national cost calculator for delivering FAME has updated information in it. And we've also been looking at, again, what are the elements of fidelity and quality that we need to have a particular eye on to improve the delivery of the programme. And then the third question, which was about, what works to maintain fidelity and quality? What can we do? What can we implement as part of a national programme that would make sure that quality and fidelity were delivered over time? And so that community of practice platform was really important, so that there was knowledge sharing at national level, but also that there was local quality assurance systems in place. So making sure that the programmes continue to deliver to deliver FAME as it was originally conceived was really important. One of the things that any intervention needs to have with regards to fidelity is a notion of what is absolutely non-negotiable. So what is it about this intervention that you cannot mess with? There might be things that you can change. You can change the venue, you can change the what people wear, you can change whether you have tea and coffee afterwards, you can change how many instructors you have in the room, but what you can't change is the active ingredients in the actual intervention. And whatever the intervention is, there needs to be some scope to adapt it to the local context, but there also probably needs to be the secret ingredients, the things that actually make it work. They shouldn't be changed. So knowing what that is really crucial. It's important to have kind of benchmarks so that you know what you're striving for in terms of outcomes. And of course, there does need to be funding. So these are the kind of results that we got through the interviews, through the data analysis, the routine data analysis, and through the document analysis. And so the idea now is that we will kind of synthesize that into updates on the components of the implementation toolkit. So we will have updated information about quality assurance, about data collection, about the business case, where to take that business case and how to kind of foster support at all levels. So we're just in the process of kind of looking at how to update the toolkit, and we'll continue to do that while we do the additional case study analyses. So I've kind of touched on it quite a bit while I've been explaining the results of what we found, but what does this tell us about how we spread FAME? So what have we learned from all of this? We've kind of done the academic bit. We've described in academic papers that we're writing up now how, which of the CIFA codes that we've, identified as being important. We've mapped it against the Carroll framework to see, what that adherence and modifiers looks like. We're doing the, updates on the costing tools, but what do we actually do differently now in the real world? So one of the things that we did as part of the Flexi study is work with what used to be called the Academic Health Science Network in the Southwest. They're now called Health Innovation Networks. We were really interested in the model that they've got in the Southwest of spreading interventions. And they've used a methodology that's come from the Billings Institute in America, where they've successfully implemented programs like introducing new housing for people who are homeless, and how to get people who are homeless in Times Square in America off the streets and into secure permanent housing. Not secure as in locked in, but permanent housing. So in their methodology, they really place an emphasis on your intervention solving the problems that your commissioners or the person who's going to implement your intervention has. So instead of saying, how do we get all these people to commission FAME? You know, how do we get them to do what I want them to do, which is to implement FAME because I know it works and it's effective? That's the wrong question. So the right question is how can I help these people do what they want to do? So the Integrated Care Board they want to break even, they want to improve the health of their population, they want to deliver effective evidence-based interventions. Ultimately, they want to reduce demand on services so that they can deliver the needs of the population. So how can FAME help them do that? Well, it's preventative, it will reduce the number of falls, it will reduce the number of ambulance call outs, it will, save them money. There's a positive return on investment. And so we need to go to those commissioners to say, well, what are the things you're struggling with? Well, this is how FAME can help. If they tell me they're struggling with isolation and loneliness because they're a rural area, well, actually FAME can help with that, because we've shown that, people tell us all the time that the social aspects of the delivery are really, really important. If it's around mental health, well, we know that FAME increases physical activity, and we know physical activity is good for mental health. So it's not kind of spinning, it's not lying about your intervention or trying to make it something it isn't. It's using the evidence that you've got, but framing it in a way that meets the needs of the person who you're trying to influence. And so as part of that Billions Institute methodology, one of the things that we were encouraged to do was to really focus on what it is, what's our pitch, what's our story, what is it that will get the hearts and minds interested in FAME. So we spent quite a lot of time working out what it is. Yes, we could say implement FAME because it will reduce falls, or implement FAME because it will save you money. But actually, what we know is that everybody has, friends, relatives, older relatives who they can think of who could be at risk of a fall. It might be a parent, a grandparent, an aunt and uncle, next door neighbour, but you can imagine those people because they're close to you. And so what we aim to do was to make the case that FAME could help people to get up, stay up, and live their best lives. So it's a very positive kind of strapline, I suppose. It was, FAME is something that is going to keep people living their best lives. They'll be able to play with their grandkids on the floor. They'll be able to stay in their own homes for longer, get down on the floor to read the gas meter. They'll be able to tiptoe up on, get things out of the cupboard to eat. They will have the strength to be able to do all those things for themselves. So that was the positive image we wanted to present. And then we took the learning from the various studies that we've done to say, okay, what local action do we need to take to try to make sure that we're promoting FAME in areas where there is local need, or where they've already shown that there's a will to introduce something to prevent falls. So we're thinking about those CIFA constructs. It needs to be better than what they've got already. We need to find a way of having some credibility to kind of promote the programme. We need to be able to help them problem solve. We need to be really clear about what FAME is, what are those core elements. So a lot of that kind of theory from CIFA we've used to influence how we've amended the toolkit, but also now how we're actually taking action to try and spread the intervention. So what have we done? We've done some needs mapping to look at which areas have FAME as a priority, a strategic priority. We've looked at stakeholders of who needs to be influenced in local areas to increase adoption. We've run programs like away days and events, communities of practice large events to try to get those opinion leaders next to the providers of fame, next to the postural stability instructor, the instructors, to try to get them talking to each other, to get an enthusiasm. So we held an event in Devon in June last year, where we had the medical director of the Integrated Care Board right the way through to voluntary sector and instructors, all in the same room, all doing activities together, all looking at how we could spread fame. And so we had that champions at every level in that meeting. Really framing fame so that it is solving the problem that they've got locally, rather than just kind of banging on about the fact that it reduces falls and it's evidence-based and it's, brings a positive return on investment. And then thinking about how we provide that expert support. So we've got the toolkit, which is our how-to guide, but we've also been putting on these networking events, and also we've created a new team that we've called the National Fame Implementation Team, who is people from Physiotherapy Society, Royal Society of Prevention of Accidents, lots of different experts around falls, all together in one place, who can drive implementation forward. And hopefully that is starting to lead to increase in buy-in. So what does the needs assessment look like? So this is work that Rob Vickers from the ARC in the East Midlands helped us do. So he and some students sat down and looked at all of the Integrated Care Board strategies from across the country, and looked at areas where there was a high degree of interest in falls prevention because they'd mentioned it in their strategy. But also he looked at the admission rates for falls and fractures related to falls. So in the top right hand corner, you can see there's a list of integrated care boards that are both interested in interested in falls prevention, and also have a high need because they have a high rate of falls or fractures and admissions in their area. And so that we now have this sort of shorter list of areas that we really want to actively engage. So that's that top right hand corner. And we'll start with those. So it's the kind of coalition of the willing, those who really want to make a difference to their falls rates in their area, have high need. That's who we need to actively engage first. And as you can see there, we've mapped that out across the country, so we know where these sites are to work with next. In the model for unleashing, which is this Billions Institute model, then we as researchers can't do this on our own, and we shouldn't do, really. We've done the research, we've developed the evidence of what works, we've put it into resources, but we can't be the ones that take this into a national kind of rollout. So at some point we need to kind of be handing this over. So this model for unleashing is really a way of helping people think about, what's your goal here? How big are you aiming to get? How many areas are you looking to get this intervention spread into? Add a few notes onto that to be ambitious, but you need to have a mechanism of the spread taking on a life of its own, rather than it just being under your control. So, and that's a real challenge. But what we've done to help us do that is create this team, this National Fame Implementation Team, whose job it is to promote and spread fame, be the experts, be the people that local areas can come to for advice. And that's different to the Flexi study and the physical study, which was all about the research side of it and understanding how we spread fame. So this is the event that we ran in June last year. We got a really wide range of people together to look at how to address the issue of falls in their local area. But again, our strap line was a positive one about how do we help people live their best lives in Devon. And it was a really well attended and successful event, lots of enthusiasm. So in Devon, when we first started the Flexi study, there were about 13 FAME classes that already existed. And by the time, and our ambition, that Billions Institute method, what's your number, what's the scores on the doors that you want to achieve? Well, we said, or NFIT said, we want to double the number of FAME classes in Devon. And now we're a situation where we've got 53 classes in Devon. So there's been a really big push, a real successful spread of this innovation. I wouldn't, partly attributed, I think, to the work of Flexi, of NFIT, and of the learning from the physical study and development of the toolkit. Stopped. Okay, oh, that's just the different types of programs. Ooh, and there's all the people that have now benefited from FAME. Okay, so what we've done the early trials were done, the evidence was generated. Some sites adopted it anyway, just really early adopters. But in the meantime, FAME made its way into national guidelines, into NICE guidelines. It then we did the physical study, we looked at the real world implementation, developed the toolkit. That has been downloaded, I think, over 2,000 times. And we've just done a research study looking at what people have done with that when they've downloaded it. How has it influenced their implementation of FAME across the country? We then created the NFIT group, which is not funded. This is just people who are willing to try and increase the availability of this intervention. We're looking at how we now make that a more sustainable organisation. But we have seen growth in the likes of Devon. And you can see in yellow there some of the constructs from the CIFA framework about, having the evidence base, showing that it's a good intervention to deliver, and that's through your national guidelines. Having the resources to kind of influence people's beliefs about something, so that is that kind of knowledge about the intervention, believing that it works. And then the NFIT bit of it is about the engaging leaders, about getting the hearts and minds on board. And that's just, I've just come to the end. So I'll stop sharing now. So that's the story of how we've taken an intervention that we didn't develop, but we've studied its implementation, turned that into some real practical resources, and hopefully now we've got some generalisable learning, both for that intervention, but also other interventions and how we spread them. So that's it, and happy
Lovely.
to take questions.
Thank you, Liz. I really enjoyed hearing it, because I've kind of been there and seen it happening, but at arm's length. But I think it also shows that it just does take such a long time for evidence to get into practice. So from 2015, when Dawn created the intervention, we're in 2024 now, so 19 years and counting.
Yeah, I mean, that's it. So, and just the inception of it back in the 90s, it was really, she believed that it was going to work, and then it's just the accumulation of evidence and systematic reviews, and the number of times it's been shown and shown and shown again. So now working at the end of actually implementation is really exciting, but as you say, it's just taken such a lot of work.
Yes, we have got some questions, which is lucky, because I was going to ask you a really nasty one. So anyway, so Victoria says, sorry, she only caught the end, but it looks like her trust, so RUH, so Royal University Hospitals Bath, was down as low interest. Can you please contact her, and she'll see if she can look into that one, and she's added her email address. So Victoria, I will pass on your email address to Liz. And then Esther, do you have any advice about how to start building collaborations with ICBs and councils, and how to make these collaborations remain meaningful over time?
Yeah, I mean,
well, Esther, it's almost like you're reading my brain at the moment.
So what matters is personal kind of relationships. I can't emphasize that enough. You need to get to know the people who are interested in your whatever your intervention is. So I don't know what your particular area of research is, but I don't know, let's say it was diabetes. Then it's getting to know who are the commissioners, who are the people who lead on the commissioning of diabetes programs and you can start with your local ICB, Nottinghamshire, just to kind of get familiar with it. But who are those people? How can you help them solve their problems? So if they're recommissioning services, can you provide evidence? Can you summarize evidence into really digestible pieces? Just build that relationship, and then you then might get invited onto steering groups. They might contact you to ask your advice for things. It is about really getting stuck in and building the relationships. There's no one simple way of building relationships with all of the ICBs. It's kind of thinking about, well, can you use the voluntary sector? So with your intervention, whatever it is there a particular lobby group that you can work with and they can do some of your influencing and networking? I mean, it's just, I could go on and on and on, but it's not, there isn't a single sort of silver bullet. You've got to.
And I think it is that issue when we talk about lots of engagement, we talk about implementation, you have to engage. That's often not seen as a research task in itself. It's, you must collect your data, you must get your publications, you must get grant income. Actually, you have to, if you want to do any of the meaningful implementation work, you have to invest in that engagement work as well, which is a really tricky thing to do when you're an academic contract and some of the power relations there as well.
It is, but luckily, I think the mood music is changing a little bit. So REF is focusing much more on impact now, and there are funding pots that you can apply for to support implementation and impact. So and again, this is a big body of research here. So this isn't you've just done your PhD, developed a new intervention, and you just finished the feasibility testing. This is many studies that have been pulled together into a body of work. But there is funding available for implementation type work. But having things like toolkits, guides to how-to guides, or simple one-page sort of infographics about what your thing is, what your intervention is, would be a really helpful dissemination activity.
So it moves on to the point Lindsay's just raised. So echoing what we were talking about earlier, research takes a long time to get implemented into practice, and this is often a reason why people tend to disengage with research. Are there any implementation tools that you can use as studies are in operation? And secondly, will the toolkit be updated regularly?
Yes. Okay, so the toolkit for FAME we'll be doing what we're moving it. We had it as like an interactive PDF, so you could download those documents and customize them locally. The work that we did to figure out how people have used the toolkit told us that people would prefer it if it was a kind of website where they could go and kind of more easily navigate and download documents. So we're just looking at the actual format of the toolkit at the moment, but how we can still capture impact and how people are using it. But we want it to be accessible. We want it to be commonly known about, and so if we do move to a web-based system, then we can literally keep it updated as new things come along. But again, that requires funding, so we're working with Later Life Training who train the instructors to host that, because then they can keep it updated, and they'll want to keep it updated because it's part of their program. But it also means that we as researchers, when I retire or when people leave, there'll still be a legacy there to keep it updated. I think the issue about tools you can use as studies are in operation. I mean, it is difficult with the timeline being so long in research, because working in local authority, we want interventions now. We don't want to wait until the 10-year research study is finished, and that's a real challenge. So I don't know if there's anything easy there. All I would say is the more you build feasibility, acceptability and affordability into your intervention, the more likely it is to be adopted at the end. Because if it's brilliant but it's massively expensive, then is it realistically going to be adopted? Probably not.
Yeah. So actually, if we have other questions, we've got a few minutes. If anybody wants to pop anything in chat or raise your hand, I was going to ask something quite similar. And I guess it's that hybrid role that you've got both as a public health commissioner and as an academic. Is there any way that we can make research quicker, or that we can share learning if it's not quite ready enough? So you just pointed out that it can, as academics, it can take us a decade because we want to do trials and then we want to test it again, whereas actually from a practitioner, commissioner perspective, I guess you wanted it yesterday.
Yeah, I mean, I think there are mechanisms now evolving of doing rapid evaluations. So in public health practice, we often don't have evidence that things are effective. So we implement programs, but have a monitoring evaluation, sort of rapid development type approach. And also there are now NIHR fund. Actually, I run an evaluation team at Nottingham where we can be commissioned to evaluate interventions in local government. So that's evaluation rather than doing research. There's probably some things where we don't need to do the research again. We don't need to do research to show that being more active is better for your health. So again, it's about being proportionate. I think about what needs testing from a kind of research point of view, and what can be, what is it's likely that it is going to have a positive effect. Implement it, but evaluate it. So monitoring and evaluation as you go. Obviously our mantra is always kind of, evidence-based practice. You need to kind of implement things that have been shown to be effective, because that's how you use the public purse to best effect. But I think there are definitely situations, and we saw that in COVID, where we just go ahead, but it's really important that you implement the monitoring and evaluation if you are going to do that.
Yeah, lovely, thank you. Anybody else got anything they'd like to ask Liz?
I mean, if anybody out there is developing an intervention or is interested in understanding how to influence commissioners at the end of it, I'm more than happy for people to contact me and have a chat about that. That's not a problem. Holly Knight, who's in my first the evaluation team, is really keen to hear from researchers who are doing implementation research and kind of form a, sort of looking at that community of practice approach between researchers too.
Yeah, and there's, it's a very hot topic in ARC world at the moment, and Archer world overall. So actually, I guess it's saying people watch this space. If you're not in the East Midlands, watch this space in your local ARC area as well. Stuff will be happening in the next probably 6 months, trying to bring lots of this stuff together. So thank you, Liz. Again, thank you everybody for today. It's been a really useful chat, really interesting webinar as well to listen to. We will circulate the link and an evaluation form, so please do let us know what you think. And yeah, thanks again.
Okay, well, thank you. Thanks for your support, Emma. And the ARC East Midlands has been great at supporting all of this research.
Thanks, Liz.